They overlap definitely, but it's a little bit different perspective in looking at it. I use the term up here lymphoid organs, which is more common in Europe for them to refer to it in that way, and you're using a British textbook, and so it uses that term as well. But don't get caught up, whether it's lymphatics, lymphoid, or immune. Slight differences, but just we're going to consider them all the same thing here. Basically, lymphoid tissue is going to be immune tissue, immune cells, morphologically homogeneous here, but functionally heterogeneous. In other words, it looks a lot alike. It just looks like a lot of nuclei in there. But when if you were to look at it, and we're not going to go down at the cellular level per se, you're going to see there's B cells, there are, I'm going to say lymphocytes, there will be plasma cells, there will be macrophages, occasional eosinophils, basophils in there, and so on. But primarily, it's lymphocytes and macrophages in there. In terms of locations, where do we find these organs that we're going to be looking at? Well, this figure, realize last night, I probably want to look for a different figure. It just shows a little bit too much in here. Where do we find it? Well, tonsils. And, they label tonsil, and they label adenoids, which is just your pharyngeal tonsil. And so that's why I don't like this figure as much. It does too much labeling. It could have simplified it, per se, in there. Where it really doesn't overkill is lymph nodes. Lymph nodes, are scattered all over the body. Well, they show them multiple places, label them multiple places throughout the body. But we will look at tonsils just in general. We will look at lymph nodes. We will also look at spleen, spleen being our largest lymphoid organ. We'll look at the thymus, which may have rivaled the spleen in size when you were born. And then we'll talk about the idea of the fact that throughout the body, not only do you have lymph nodes throughout the body, but in organs throughout the body, you will have clusters of what we're going to call diffuse and nodular lymphatic tissue. Okay? We're going to see later blocks, in fact, I think respiratory is what we do next. There's a slide of the lung. I'm going to point to this and say, what is this? And because it's the previous lecture, you guys are going to say, oh, that's a lymphatic nodule. Okay? And so anytime you have a site of infection, be it in the lungs, be it in your tongue, be it in a salivary gland, any organ you want to think about, we can find lymphatic tissue. Okay? Because remember, that's what fights off that infection, and it will migrate to the source of that infection. All right? And so, we talk about lymphatic organs, but we've got to say you'll find lymphatic tissue virtually any organ of the body. It represents, we took this out of order when I wasn't looking at the notes, it's a storehouse of cells of the immune system that are responding to some type of antigenic response right here. And they will disperse throughout the body to where that infection may be. All right, I've already talked about the cells, macrophages. The macrophages are derived from blood monocytes, which are going to be coming from bone marrow. Lymphocytes and plasma cells, those are the three biggies you see in there. And realize a plasma cell is just a B lymphocyte that's converted into an antibody-producing factory, correct? But then you'll find neutrophils, eosinophils, occasionally basophils in there as well, but really the first three, A through C, are the ones that will be the most common. Now, we'll start off what we call diffuse lymphatic tissue. This is a slide that you can't appreciate just yet, per se. And boy, it's pixelated, at least on that screen. Not as much up here, still pixelated a little bit more than I would like. But basically, what we're looking at here, these finger-like projections are villi of the small intestine. And what we could say is when you start looking at the small intestine, you're going to say there's a lot more little black dots in there. And of course, those black dots are nuclei. And when we talk about diffuse lymphatic tissue, that's what we're talking about. There's just more lymphocytes, there's more macrophages in there, so it looks like more nuclei than there should be. Okay? And certainly you can look up there and say, yeah, there's an awful lot of nuclei, but you don't know that's abnormal per se, because you haven't looked at this. But I'll look like right in here, there's a whole lot, or right in here, boy, they're really concentrated, aren't they? But they're there's just too many of them. That's what we call diffuse lymphatic tissue. and it takes a little bit more of a trained eye. And once again, if we're covering the GI tract, I'll pull this same slide up. This is actually from one of our lab sites that we use. I'll pull this same up and you'll think, whoa, that looks a little bit different than the previous three we've looked at. Oh, there's more nuclei in there. Okay, diffuse lymphatic tissue, that makes sense. Okay? Now, diffuse lymphatic tissue, if you wanted to go find it, you typically are going to look in the connective tissue just underneath the epithelium of your GI or respiratory system. Why? Well, those are front lines in terms of fighting off potential infection. The food that you eat is not sterile. Certain foods definitely are not sterile. And so if those bacteria begin to make their way through that lining, there's your front line of defense. We've already talked about the air you breathe in is anything but sterile, correct? And so once again, front line of defense, but we can find it virtually any organ of the body. Urogenital system, I've got a slide that shows it in the salivary gland later on. We're doing oral cavity. Any system of the body, any organ of the body, you can potentially find diffuse and then potentially nodular lymphatic tissue. All right, what do I mean by nodular? Well, diffuse is, bacteria are making their way in through the lining right here. Let's get cells of the immune system there. If those cells right there are enough to take care of that infection, we were to look at this, and can't really do it, but if you could look at this same place in the body a few weeks later, it would look normal again. Okay, you build up that clonal army and then you disperse it, correct? Okay, you get rid of it once that infection's gone. If this is not enough to fight off infection, you keep getting more and more and more cells there. It goes from being diffuse lymphatic tissue to nodular lymphatic tissue. And this is a lymphatic nodule right here. Okay, what I'm circling is a lymphatic nodule, and all of this surrounding it here is a lot of nuclei, isn't it? That is diffuse lymphatic tissue that's just piled, gotten much closer and closer together, but this is a nodule. A nodule would be exactly what you would think. It's going to be a round or oval-shaped structure where there's just more of those nuclei concentrated there. All right. Now, once again, these are non-permanent structures. If a nodule is enough to get rid of that infection, once the infection's gone, most of those cells will die. Other memory cells will disperse throughout the body. Okay? If a nodule in and of itself is not enough, if you maximally have to turn on that immune response, the nodule will develop a light center to it, which this one right here has. If you take a look in terms of the entire nodule, circle the entire nodule here, but it's got a lighter middle to it, doesn't it? That lighter middle portion is called the germinal center. And what that germinal center represents is maximum proliferation, maximum cell division of those B cells, those plasma cells. Okay? And these images here, just looking in more detail, once again, I am not that concerned. We're not going to say, oh, that's a macrophage, or that's a plasma cell, that's a B cell, that's maybe just a T cell. We're not going to get in at that level. We don't need to in terms of setting up the groundwork for pathology later on. But there is a nodule with a germinal center, and they're just showing some more detail, higher power that we're not going to worry about. We're going to see tons of germinal centers tons of nodules in these lymphatic organs that we're going to be looking at here in just a second. But once again, these can show up any organ of the body, okay, if there is an infection at that site. All right, let's shift now to lymphatic organs, and as we do that, we're going to start off here with the thymus. You probably have seen a drawing similar to this in immunology. Thymus is a bilobed organ suspended from the roof of the thoracic cavity, comes down and drapes over the heart. That is in the newborn. Okay, the thymus is one of our, what we call our primary sites or primary lymphoid organs. In other words, it's where B cells, or in this case T cells, originate, where cells of the immune system originate here. And that's the T for T cells comes from thymus-derived cells. All right. Now, if we look at it histologically here, this is what it looks like. Okay, the T cells that are going to be made in here are going to be seeded to other organs throughout the body, primarily bone marrow, and consequently, this would be a thymus gland of a newborn or a 3-year-old or something like that. This is your thymus gland over here. We'll talk about that in just a little bit. Okay, whereas it initially is a large organ, in case it comes down, drapes over, maybe don't show it, I've seen actual surgical photographs which shows it draping over the heart and then retracting it to the side in order to do heart surgery on a newborn. In you, it's about the size of the last phalange of your thumb. Okay, just a little nub hanging up there. All right, why? Because all the T cells that develop here were seeded out to bone marrow and other places throughout the body. Okay, decide where they develop, and then they leave to seed other organs. All right, if we go back and look at it histologically here, describing it, it's got a capsule on the outside of it, and the capsule then has connective tissue branches that we call trabeculae, and that's just a common term. We've got branches coming off of the capsule going internally, that's a trabecula, trabeculae plural. But those trabeculae do divide it off into lobes, but not all lobes are completely divided off. And so it's incomplete lobulation, but it's pretty close to being complete. Okay? Partial complete lobulation might be a better term to describe it there. We're going to see other organs like the spleen, trabeculae coming in, but no hint of lobulation. This has a pretty good hint of lobes to it, doesn't it? You can see little islands, so to speak. Like right here, the pointer is in the middle of a lobe. Right here, the pointer is in the middle of a lobe where those trabeculae have divided it off into a lobe. All right, now stepping out from it being in lobes and looking at it as an overall structure, it's got a dark staining outer portion and then a lighter staining inner portion in here, doesn't it? The terms that we use to describe, we've got an outer part and a middle part, is an outer cortex and an inner medulla. And so it's got a dark staining cortex, a lighter staining medulla. Now, sometimes we see that in an individual lobe. I mean, look at this lobe right here. It's got a darker cortex and a lighter staining medulla, but normally it's the entire organ. Don't look at it in terms of lobes with outer cortex and inner medulla. It is the overall organ, for the most part, that has a cortex and a medulla, not at the level of each lobe. Okay? Now, the cortex why is it so dark staining? It's a very dense population of T cells. And you know from immunology, you know better than I do, there are a lot of different subtypes of T cells, correct? As those T cells develop into different subtypes, as those T cells determine what antigen they're going to respond to, they're developing out here, but they will move from the cortex towards the medulla as that is happening. And there will be macrophages in here as well that will remove T cells that aren't needed, aren't wanted, some of which might be responding to self-antigens, okay, which we don't want, of course. That they're not as numerous in here within the medulla, and that's why it doesn't stain so darkly. And there are a lot more supportive cells, structurally supportive cells in there that we call reticular cells, sometimes called reticulocytes, and another type that we call epitheliocytes. And you don't have to identify those two per se, just know that in fact they are in there. Now the epitheliocytes do something unique. We're now down within the medulla. They form these structures right here that we call Hassel's corpuscles. And reasons that we don't understand, don't have an explanation for, these epitheliocytes, as they get old and worn out, they spiral around each other. And this is a nice image here showing you that you can kind of get the idea that cells just kind of spiraled around each other as they're worn out, as they're getting ready to die, they will form these Hassel's corpuscles. Now you don't always see a nice image like this. A lot of times it may look something more like this over here on the right, but those Hassel corpuscles are, unique. Nothing else really looks like that. And they are found within the medulla of the thymus gland. Okay, the next thing I've got in the notes here, I've already talked about the clonal selection, removal of T cells that are going to be directed against self-antigens. All right, now once all of those T cells are fully developed and we've got rid of the ones that are going to be responding to self, those cells will then be seeded, like we said, throughout the body, and that's when your thymus goes from looking like this to looking like this. Okay, that's called involution of the thymus. It involutes, it kind of shrinks in on itself, and you can see there are still patches of that dark purple. Those are still T cells there, but most of it is adipose. All of the white you're seeing in here, that's adipose tissue, and like I say, it shrunk up to maybe half the size of your thumb. Okay, maybe the full size of your thumb, something along those lines, but it's not very big at all anymore. Okay, the thymus is where T cells are derived from. That's just a primary lymphoid organ. The other primary lymphoid organ would be where the B cells are derived from, and that is bone marrow. We aren't going to look at bone marrow other than what we have seen. We looked at the megakaryocyte. But we said bone marrow is primarily white blood cell development, correct? It's got red blood cell development, yes, occurring there, but if we look at it, the majority of cells are white blood cell precursors. All right, what we will now talk about is the secondary lymphatic organs where those T cells are seeded out to, as well as B cells that are derived from bone marrow have seeded out to. The first thing we're going to look at here is what we call GALT or gut-associated lymphatic tissue. All right, if we take a look right here, here is the lining right here of the small intestine. You can't tell necessarily, but it's a simple columnar epithelium. And then look at this. I see something where I just see a lot of dark staining nuclei. What you want to start thinking when you see that is lymphatic tissue. And you'd be correct. It's a large lymphatic nodule. Look, it's even bulging up and pushing this epithelium up higher. And it's starting to get, or maybe it's starting to degenerate, one of the two. Got a little bit of a germinal center right here, doesn't it? Not as, it doesn't jump out at you the way the previous one did, but that is a lymphatic nodule. There's certain places, I'm going to say there's one place in the GI tract we always find these within the ileum, and we refer to them there as Peyer's patches, okay? And we'll get those in more detail when we get to the GI tract. But that's one place we know we can always go to find lymphatic nodules, just in the wall of another organ, okay? But once again, these can be found a lot of places. I mean, you can find them, I've got a slide of the stomach where you see a lot of them, okay? And when they're associated with the GI tract, refer to them as GALT, gut-associated lymphatic tissue. And once again, because the food you eat is laden with bacteria, these are common occurrences. You may have some of these now, or you certainly have them in your small intestine, but you may have them in your stomach, your esophagus, whatever. You're not feeling sick because they're taking care of that pathogen before it makes you feel sick, before it's out of control and makes you feel sick, okay? Now, GI tract is the most abundant places where we have GALT. We sometimes find them in other, just underneath other epithelial lines, refer to them as MALT there. MALT stands for mucosa-associated lymphatic tissue. Mucosa is just saying I've got a moist lining, okay? And MALT, some textbooks will list MALT and GALT separately. That's what your textbook does. Other textbooks will list MALT, and then GALT is a subcategory of it, okay? I mean, because technically the lining of your small intestine is a mucosa, a moist surface, okay? And so, I can see where they can say, okay, GALT is a subset of MALT, but not everybody does that, okay? Now, let's move on and talk about lymph nodes in terms of as an organ. Okay, here is a lymph node on very low power magnification, basically a magnifying glass almost, magnified 8 times, that we can see some of the things we want to describe here. You know that lymph nodes are found multiple places, I mean, all over within the body. You've had a lot when you were talking about organs and anatomy, you were talking about where does it drain lymphatically, because if you have cancer and infection, that's where it will show up within the lymph nodes. The lymph nodes, of course, we looked at, and you looked at anatomy as well, are found along lymphatic vessels, that as those lymphatic vessels collect that extracellular fluid and pass it back into the venous side of the circulatory system, that they will immunologically screen that lymph in these lymph nodes. Well, let's look here at the structure of a lymph node. All of the internal structure in here, yes, it's got cells of the lymphatic tissue. I hope you've looked at this and said, I see lymphatic nodules with germinal centers. I also see diffuse lymphatic tissue, and I see lymphatic tissue down here, darkly staining a little bit differently. But the internal scaffolding there is going to be reticular connective tissue, and we described reticular connective tissue as providing that scaffolding that you can suspend primarily cells of the immune system within. And most slides that show you that reticular connective tissue have taken to a lymph node or spleen and stained it, not to show the immune cells, but just to show the reticular fibers there. Okay? Now, that also is going to have a dense irregular connective tissue capsule. You can see that up here. See that capsule surrounding it? We can see it down at the bottom as well, some places better than others. So if we look down here, I've got that dense irregular connective tissue capsule running right here as well. You know that lymph nodes, when there's infection there, they swell up and they are painful. And the reason that they're painful is you're stretching on that tough leathery capsule that doesn't want to stretch that much. Okay? Now, if we take a look, and even when you see at this low power magnification, just deep to that capsule, there is an open area. If we look at that at higher power magnification, here's a capsule up top here. Here's all the nuclei of that lymphatic tissue. Here's that subcapsular sinus right there. So there's an open area called the subcapsular sinus just deep to the that capsule, hence the name, subcapsular sinus. If we take a look once again just below that subcapsular sinus, that's where we've got all of that dark staining lymphatic tissue. And as we go around, we see, something like this is not nodular, where I am passing through right here. That's not nodular, so that's all diffuse lymphatic tissue. Whereas here we see plenty of nodules, and the nodules tend to be right up against that subcapsular sinus for the most part. There's some that are not. And I'm looking through here, right here, I'm circling a nodule without a germinal center, and I'm going to get the pointer to move the way I want to. Right here circling is a nodule without a germinal center. Here's another nodule right here without a germinal center. But most of the nodules in here have a lighter staining germinal center, don't they? Follicle is a term that's used a lot of times in describing nodules. I don't tend to use it a whole lot. Okay, nodule is a more descriptive term in that. Follicle is more of a general term in terms of describing that. Okay. And then these nodules, you're always going to see nodules like this in a lymph node. But once again, they are temporary, because once this one has taken care of whatever antigen it was fighting against, it will disperse. Another one might develop right here with a new antigen. We come back 3 months later, something to a completely different antigen may have a nodule right there. Yes, you're always going to see nodules in lymph nodes, in tonsils, in spleen, but they're still temporary because they're just there long enough to fight out the antigen they're in contact with right now. Then they'll disperse, and at that time another antigen is going to come along, and you'll make another nodule right next to it, or maybe in the same place. Okay? That's confusing to some students when they look at this. They say nodules are temporary, but you always see them in these organs. Okay? That's because there's always some type of antigenic response being generated. Now, If you look up here, I mean, this is a cortex once again. Got a cortex and an inner medulla. Those are just general terms for certain organs, if we can see a difference. Up within the cortex is where we find diffuse lymphatic tissue and the nodular lymphatic tissue. If we look here in the medulla, we've got what we call cords of lymphatic tissue, okay? Fat strings of lymphatic tissue. And we can go look at those a little bit higher power magnification right here. Basically, you've got regions in there that are going to have these cords of lymphatic tissue, but you're also going to have sinuses in between, aren't you? Open areas in between where fluid, where lymph can move through. Now, the last thing to talk about structure before we start talking about function, what's going on here, is to look at this drawing and realize we have vessels coming into into lymph nodes that would be our afferent, and then we have only one leaving, which would be our efferent. If you take a look, there are multiple, this is showing 1, 2, 3, 4 of the afferents bringing lymph in, and 1 bringing lymph out. Kind of like I've heard many casinos are. A lot of nice big entrances to come in, to get out. You've got to find one in the very corner hidden in the second floor, okay? They don't want you to leave very easily, and that's the same thing we're going to see we want here. We want the lymph to get in rather easily, but we want it to have a hard time leaving, okay? All right, let's talk about function. I kind of alluded to that already right there. Basically, what you've got here are those afferent vessels are bringing lymph in, and they are dumping it right into that subcapsular sinus, okay? You can see that here in terms of this drawing. You can see that here in terms of the stain, that you've got that subcapsular sinus. Once again, that whole purpose of that subcapsular sinus is to make it easy for that lymph to get in, okay? We're going to make it very easy for that lymph to get into this lymph node, easy flow for it to come right in. Now, once it gets in there, it's got to mingle among, it's got to flow right past all of those immune cells, okay? Why? And that's where we're going to make it slow down. We want it to mingle and have a hard time kind of flowing among all of those lymph cells. Why? We want to expose the lymph to all those immune cells to see if they say, hey, I recognize an antigen right here. I need to build up an immune response against it. Okay? Makes sense, doesn't it? And if you think about it, we made it easy to get in. We made it hard to get out. And so they've really got to meander and mingle and so on before they can find that efferent, let's say before the fluid can find that efferent vessel and make its way out of the lymph node. So we're maximizing exposure to these immune cells to determine if there's any antigen in there we need to mount an immune response against. Now also, when we look within the lymphatic tissue here, we're going to find postcapillary vanules. But the postcapillary vanules, if we look at them, this would be a plastic section stained with fluidine blue. The endothelial cells aren't pancake-like, they're much fatter. They don't look like typical simple squamous cells. They're much fatter, so we refer to these as high endothelial vanules. They're postcapillary vanules. And what did we say postcapillary vanules did? These were the sites where you could have white blood cells squeeze in and squeeze out of the circulatory system, correct? It makes it so that if a cell says, hey, I've just located an antigen here, we can have other cells of the immune system now come out of circulation, squeeze out through the wall, and join in that fight against their specific antigen. Okay? Once that antigen is then recognized and we've recruited cells there, we're ready to go from being diffuse lymphatic tissue. Those cells divide, that's going to make nodular lymphatic tissue. If those B cells maximally divide, we're going to then have a germinal center within that nodule. Okay? Does that make sense? I mean, you think about what you learned in immunology, it makes a lot of sense what we're describing right here, doesn't it?
So it's just the B cells that are going to be creating the germinal center, not the T cells?
That is correct. If we look at you're one slide ahead of me. Good thinking. All right. Basically, what we've done right here is we've got an antibody on this side to B cells. We've got an antibody on this side to T cells. And what we see is that the nodules are primarily B cells, whereas just around the nodules, diffuse lymphatic tissue on the outside of those nodules is primarily T cells. Okay? So the answer to the question here, yes, the nodules and the germinal centers represent B cells. The diffuse lymphatic tissue around it represents T cells. All right, questions at all? Once again, you look down here at the bottom. A, we're staining B cells. You can see nodules. You can see germinal centers. Image B to the right, we're only staining T cells. You can kind of make out still where a nodule was with its germinal center right here. Okay? But here's the T cells on the outside of that nodule in that diffuse lymphatic tissue surrounding the nodules. And that's true anytime we see nodules. We're going to see diffuse lymphatic tissue on the outside of nodules or B cells. Surrounding the nodules is where we find the T cells. All right, let's move on from a lymph node then and talk about the spleen. All right, spleen, gross anatomy, fairly large organ located retroperitoneal, located behind the stomach. Conceptually, you can think of it as a large lymph node, but whereas a lymph node is immunologically screening lymph, the spleen is immunologically screening blood. Now, most textbooks will describe, the function of the spleen is to filter the blood. I don't like using the word filter. Filter, I think of a piece of filter paper, I think of structurally something filtering in that way. Immunologically screening is better in terms of a lymph node. It's better in terms of the spleen, but we can also say it does more than just immunologically screen the blood. I mean, we can talk about that as being a primary function. Second function, we've already talked about. This is where one of the two places, the liver and a minor extent bone marrow, is where you remove senescent, old, worn out red blood cells, correct? And we'll see how that's done as we talk about the microstructure here of the spleen. Third function, you can talk about the spleen, it acts as a blood reservoir. As we've talked about already, you've got more blood. As you're sitting here in a non-active state, you've got more blood than you need, okay? Particularly if you didn't eat breakfast, you're not having to send that blood to the GI tract to absorb nutrients. You've got more blood than you need. What do you do with that extra blood? One of the things you do is you basically inflate the spleen up. The spleen just stores it. You really need to be worried about spending energy to circulate it all that much. We're just going to store it until you eat a meal or until you get on that treadmill. And then we're going to send up. Then the spleen is going to contract its size and send that blood to your lower extremities. Okay, and so it's a blood reservoir, and you kind of have an understanding of what we mean by that. When we think about a response to different physiological stimuli where we have to send blood to other organs, where is that blood we're not sending it to other organs? One of the places is if the spleen is enlarged, storing some of that blood, so to speak. All right, if we talk about its histology, spleen is not something that jumps out at you and says, hey, I'm the spleen. Okay? Lymph node should jump out at you when you see that because it's got that nice capsule, subcapsular sinus, and all those lymphatic nodules are right underneath that subcapsular sinus. And then you can look for the other things that hey, that's what I see when I'm looking at a lymph node. Spleen, first of all, it's got to have a capsule on the outside of it here, labeled with a C, and you can see the slight pink line here coming across here. It does have trabeculae coming off. I don't have one where I see it coming directly off of the capsule, but it is coming off in front of the screen and the capsule here, and then it happens to catch right here where we have the little bit of a Y-shaped trabecula coming in here, but it has no hint of really providing lobes, does it? You're going to see branches of it coming in. Here's another Here's some other pieces of trabeculae, here's pieces of trabeculae, here's pieces of trabeculae down here, but really does not provide lobes to the spleen. You don't even, we said it was almost complete lobulation. We looked at the thymus gland, not even really a hint. You can find plenty of trabeculae, but no hint of lobulation here when we look at the spleen. Spleen also has those reticular fiber scaffolding, and what we're seeing in here are cells that are suspended by that reticular fiber scaffolding. Now, when we look at it, if we were dissecting it open, particularly a fresh dissection or a surgical procedure, it's a very mushy type of composition. Maybe oatmeal with some strings in it or something like that, strings being trabeculae. And the term that we use to describe it is pulp. Parenchyma is just saying the functional part of the organ. So it's the parenchyma there, I've got that term in the notes. Soft, mushy parenchyma, refer to it as pulp. Now also when we look at it, there's going to be, with the naked eye and on a fresh spleen, there are going to be regions that appear red and regions that appear white. And so we talk about red pulp and white pulp. Okay? Red pulp is red due to the presence of red blood cells. We're going to see a special circulation setup within the red pulp. White pulp is white due to the presence of white blood cells. Okay? Now, what do white blood cells look like? I mean, white blood cells are lymphoid tissue. What does lymphoid tissue look like? A bunch of dark staining nuclei when we look at it here. And indeed, if you look at this, I hope you looked at this initially and said, oh, I do see some lymphatic nodules in there, don't I? Okay, I see lymphatic nodules. They're all over the place. Here's a lymphatic nodule right here labeled WP, which stands for white pulp. Lymphatic nodule with a germinal center. Here's another one with a germinal center. Here's one maybe doesn't have a germinal center, but you see a lot of lymphatic nodules in there. White pulp is lymphatic nodules. We're talking the spleen. The white pulp of the spleen is a lymphatic nodule. Now, why do we call it white? Because remember, it's white blood cells. To the naked eye, it looks white, but what do white blood cells look like in lymphatic tissue? Dark staining nuclei, correct? And so the regions that don't have the nodules in them, you can see labeled up here, RP, will be red pulp. It's not the capsule, it's not trabeculae, it's not lymphatic nodules, and there's not white pulp, it's red pulp. Okay? So it's red pulp and white pulp based on the gross anatomical appearance. When we stain it, it's different, isn't it? The darkest areas are the white pulp, the other regions are the red pulp. Red pulp will not be contained in a cortex. Basically, you can think of it as all being red pulp, except where we have lymphatic nodules, which would be the white pulp. That's a better way of thinking about it. Yeah, and if you look at it, there is no cortex medulla. Okay, I mean, you can't really say there's an middle region and outer region, and kind of those lymphatic nodules are throughout. They're not just in the cortex or something like that. You don't really have a cortex and medulla. All right, now in order to understand the spleen, we've got to talk about the vasculature of the spleen. All right, the splenic artery, is what supplies the spleen. Splenic artery, when it comes in, is going to then branch into trabecular arteries. You see the word trabeculae there? They are running within the connective tissue trabeculae. Okay, let me go back a slide. You'll be able to see, okay, look right here. Here's a trabecula, there's a trabecular artery running right in the middle. Other places where I see a little bit of trabeculae, connective tissue trabeculae, I see blood vessels in there, don't I? There's going to be arteries, there'll be veins running through there as well, but we're really more concerned about the arteries. Even here, you can see some small little blood vessels in there. You can see some small little openings in that trabeculae, which will be blood vessels. Okay? And so we start off there with the splenic artery. That will be going to the trabecular arteries, and then when they leave the trabeculae to go out into the pulp, then they're going to be what we call central arteries. Okay? And when they leave to go out here into the pulp, these central arteries, tunica adventitia of them is where you're going to start finding the diffuse and nodular lymphatic tissue. We refer to that then as what we call the periarterial sheath or PALS. The periarterial lymphatic, I left out lymphatic, I say, what's the L? Periarterial lymphatic sheath is simply the tunica media of a central artery, and it is where we're going to find that white pulp. If we were doing this lab with a microscope, I'd have you go back to the previous image where you see the nodules, and I'd have you go to higher power, and you would find an artery running through each of those lymphatic nodules. That is a central artery, or more properly named a central arteriole, but once again, we're not going to get caught up in that. That central artery, if you look at, here it is right here, you see the pals surrounding it, it's going to branch off into peninsular arteries. Yes? Tunica adventitia. If I said media, I misspoke. It's the adventitia, the connective tissue on the outside that kind of blends in. That's where all of that white pulp is going to be. Okay? Now, the peninsular arteries are then going to branch into what are called sheath capillaries. And those sheath capillaries are unique. They're blind-ended. They're sinusoidal type capillaries. Remember the sinusoidal capillaries where they're missing pieces? And in fact, basically the walls of them are eventually there's no endothelial cells there as they lead into the red pulp. And basically, rather than having endothelial cell line vessels for that blood to go through, it's going to be open circulation when you get out here into the red pulp. And basically, it's going to be macrophages primarily that the blood is going to have to mingle through. Okay, you have to think way back. I used the term open circulation. Remember way back in freshman biology, you talked about some animals have closed circulatory systems like man, where blood always stays in vessels. Other animals have open circulation where they basically will dump it into their abdominal cavity and the organs there are bathed by blood. Okay, I see the entomologist definitely remembering that. Insects have some open circulation. Turns out this is the one place in the body where we have open circulation, naturally have open circulation. And think about what we want to do. We want to immunologically screen the blood. Well, what we're going to do is get the blood out of blood vessels so it's not mosey up to that tunica intima. We're going to make it mingle among macrophages and other cells of the immune system, but primarily macrophages there to immunologically screen it. That makes sense, doesn't it? Okay? It also makes sense that if you've got a ruptured spleen, okay, happens in traumatic accidents like cars. Actually, I caused it in high school. Practice, the pitcher wasn't paying attention. My throw to home plate hit him. He went out complaining, wasn't feeling good. Took him to the hospital that night. They had to remove his spleen. Okay? But why do we have trouble if the spleen ruptures? We typically just have to, we hear football players doing that. Why? It's open circulation, how do you clot it? Makes sense, doesn't it? Okay? Makes sense in terms of why we have, why is that an emergent situation, ruptured spleen, massive bleeding, we're going to remove the spleen. Why? Because we can't clot blood very well there. Okay? Due to that open circulation. Open circulation there is important to immunologically screen the blood. What happens when we remove the spleen? Turns out liver can take over much of that function of immunologically screening blood due to the sinusoids there. Okay? As far as I know, Mike is alive and well and doing okay. All right. Now, once it got in the open circulation, eventually it will meander its way back here into the sinusoidal capillaries of the red pulp, which will remove it back into circulation. All right, any questions here in terms of function of the spleen? I mean, it makes sense when we talk about it here in terms of the microscopic anatomy, doesn't it? All right, next thing to talk about here then will be the tonsils. All right, tonsils form a ring around your pharynx here, and there are, depending on what textbook you look at, some books will say, there's 9 sets of tonsils, some say 11, some will say 13, whatever. It turns out there's 3 or 4, depending on which source you look at, clinically important ones. Okay, we've got 3 of those right here. The pharyngeal tonsils, you've looked at in gross anatomy. Those are, older term for that is adenoids. You'll still see that used sometimes. You got the palatine tonsil you talked about with Dr. Angstrom. That's the one, say ah, that they're looking at. Okay, and then on the back side of the tongue, you've got a lingual tonsil. Those are the 3 clinically important ones. That's the 3 right there. The other one that's sometimes listed as a 4th will be the tubal tonsils that surround your eustachian tube that connect the pharyngeal region to the inner ear. Okay, and so those will sometimes be listed as a 3rd important. This isn't gross anatomy. We're not going to worry about that per se. What we want to do is be able to identify a tonsil. And we're not going to have to distinguish between the different tonsils, but this is what a tonsil looks like. First of all, I hope my last hour has not been wasted. You look at that and say, I see tons of nodules, okay, and tons of germinal centers there. So you know you're looking at a concentration of those. Low power magnification, once again, about a magnifying glass, magnified 6 times, and so those nodules look small, but I see tons of nodules with germinal centers. It's dark surrounding those nodules. That would be my diffuse lymphatic tissue surrounding them. We've already said it's primarily going to be T cells. Now, if we were to be able to go to higher power up here, we see there's an epithelial lining. They're labeling that with E. And if you see a book that's talking about, or a website talking about, distinguishing this as being a palatine tonsil from a pharyngeal tonsil, well, pharyngeal tonsils up in the nasal passageways has got pseudostratified ciliated epithelium on the surface, whereas a pharyngeal tonsils in the mouth has got stratified squamous epithelium. Okay, and so it differs depending on where that tonsil is. Okay, you don't have to distinguish it; you just have to call it a tonsil. The thing that is, as we look here at that epithelial lining, it's not smooth. It comes in here, and then it's got little crevices come in here, and we call those crevices crypts. Okay, let's say, okay, I was going to say, let's figure out which tonsil this is. A palatine tonsil here. So this one is in your mouth. As you're chewing up food, and you've got little particles of food passing over that tonsil, what's going to happen to that food with these crypts? It's going to get stuck in there, isn't it? It's not something, I brush it to get it out. You don't brush your tonsils up there. You're going to gag, right? Yes, you're getting little tiny pieces of food in there. What is with that food that we're concerned about? Pathogens, bacteria particularly, viruses, other pathogens are there. We're basically inviting infection, aren't we? If we had a smooth surface there, we wouldn't have trouble with sore throat, would we? Wouldn't have troubles with tonsillitis. Why are we inviting infection? We're basically screening, yes. Which is better to fight off an infection, a primary immune response or a secondary immune response? Secondary immune response, correct? That's why we give vaccinations, correct? Let's go ahead and do a primary immune response and do it at such a low level that you don't get sick, okay? Or do it in such a way you don't get sick, so that when you encounter the chickenpox virus, when you're out in clinical rotations, you generate a secondary immune response. Well, this is basically doing the same thing. We eat food that has this bacteria in it. For the most part, we're eating places that, have certain populations of the same bacteria, okay, that are common, to, this country and our food source. And what we're doing is saying, okay, what I'm going to do is within my tonsils right now, I don't even have to have a sore throat. Right now, I am generating primary immune responses there so that I can generate an immunological library. And that library is basically primary immune responses against bacteria that are commonly found in the food that I commonly eat. Okay? That way, if I get too much of one of these pathogens, my food contains, so much of those bacteria, but let's say I get some food that are spoiled or something's wrong with it, rather than having this much of that bacteria, it's got that much, okay? Enough to really make me sick. Well, now I can generate a secondary immune response against it and have a better chance of not getting sick from it, correct? Okay. Now, we run into problem, we go to other countries and eat, and their food might have bacteria that we're not that accustomed to. Why does that native population not get as sick from eating that food as you do? Because they've already generated primary immune responses to it that you have not. Okay, does that make sense? Now, I love teaching this when you've already had immunology because it really just drives home that immunology, doesn't it? Is this an inflamed tonsil because of all germinal centers? It probably is, okay? You will typically find tons of nodules and germinal centers, but this is about as full as you can get, okay? Basically, how am I gonna recognize a tonsil? I'm gonna recognize it as crypts. First of all, I recognize it as immunologically an immunological or a lymphoid organ, because all the nodules in there, in this case, nodules with germinal centers. And then when I see crypts coming off the surface, that's gotta be a tonsil. You're never gonna have crypts coming like that into the spleen, never gonna have crypts coming like that into lymph node. There's other features to help you recognize lymph node and spleen anyway, correct? But the crypts are the giveaway that we're looking at tonsils here. Now, the other thing here to talk about being, the last point being enlarged, on the back side here, there's a little bit more connective tissue than normal. This one shows it a little bit. Kind of see how there's much more dark pink in here, and it's organized right around the edge of that. I've got a lab-in slide that shows it better. There's basically epithelial tissue on one side there, and then the lumen of the mouth is up here. This is upside down, because we know it's in the roof of the mouth. Okay, here's the lumen of your oral cavity up here, but there is a half of a connective tissue capsule on the back side. And it's not discrete and organized. You can't hold it between your fingers like you could, with a lymph node per se, where you can have your fingers directly on that capsule. Because it's a half a capsule, like a half a sphere is a hemisphere, it's a hemicapsule, okay? And so that's what they're labeling when they labeled C. It's technically not the capsule, it's a hemicapsule, because it's only half a capsule, the other half side is lined with epithelial tissue. All right, any other questions? All right, no questions. Let's go ahead and take a 10-minute break.